Hello guys, Andrew Chen from PSPeppaPig here. Just recording a video for you about the whole lower limb. We'll try to cover as much as we can. Mostly stuff that I think is more important. But this is the first time I've done a recording, so we'll see how this goes and hopefully it's alright. Just getting the laser pointer, okay. Alright, so we'll start with the hip bones. So, three bones here, the ilium, which is the superior one in red here, um, ischium, which is the green one here, that's more to the back, and posterior. And then we also have the pubis, which is the yellow part, and that's more anterior and inferior. So there's quite a few landmarks here. So we'll start with the ilium. So the iliac crest is basically this top part here, which kind of makes sense as a crest. And then we have the AIS, AIIS, PIS, and PIIS. So that's what that's standing for is that that's the anterior superior iliac spine for the AIS and anterior inferior iliac spine. So that's like the pointy parts here and here. And you also have that at the back. So that's your posterior superior iliac spine and your posterior inferior iliac spine. So these ones are good to know. The iliac crest and these spine ones are really good to know. Also, you should know the iliac fossa, which is sort of on the inside, so to speak, so on this side. And then you also have the wing of the ilium, which is on the outside. And we'll move on to the ischium. The ischial spine is also quite important. So let's see if we can find the ischial spine. The ischial spine is here. It's posterior. And we'll have some ligaments that are attached to here, which we'll see later. And then we'll have the ischioramus as well, which is just this part. This horizontal part, this length. So ramus is kind of anything like a sort of like a projection, something that's, I don't know, like a rectangle kind of just sticking out. So this will be like the pubic ramus as well. But anyways, we'll cover that a bit later. So that's the ischioramus. Also the ischiotuberosity, which is actually the bit that you sit on. So that's the most back part here. So if you're sitting down, and you can sort of just feel like the bottom of your butt, which you're sitting on, that is your ischiotuberosity, the bone you feel. And moving on to the pubis, first of all, we have the pubic tubercle, which might not actually be labeled here, but the pubic tubercle will just be somewhat roughly around here. And then you have your superior and inferior pubic ramus, and this is your superior pubic ramus, and this is your inferior pubic ramus. And the fusion of your inferior pubic ramus and your ischioramus might be called this ischiopubic ramus. And then the pubic symphysis is the part in the middle where they fuse, and you'll have some cartilage here. So where all three of these bones meet, here and here, is called the acetabulum, and that's gonna form your hip joint with the femur, which is with the femoral head. So this is just the Netter's diagram of it. It's quite detailed. You don't need to know everything, but it's good to learn the landmarks that we mentioned before. And we didn't have the pubic tubercle labeled before, but here it is. So you can just see it's sort of a bulge there. And now we'll move on to the femur, which is the bone in your thigh. So this one has a head, it has a shaft, it has a neck connecting the two. And first of all, we'll talk about the greater trochanter, which is on the lateral side. So you can actually feel it on yourself. So if you're sitting down, and you just sort of try to feel the side of your butt, the side of your hip, you can actually feel it. So the greater trochanter is a site of attachment for some muscles, the gluteal muscles in particular, so your gluteus medius, your gluteus minimus, but not your gluteus maximus, and the piriformis as well. So don't worry if you don't know the muscles right now, we'll have a look at them later as well. The lesser trochanter is this part in blue, and that's more posterior medial, and that will be an attachment for iliopsoas, which we'll also mention later. And then you have your entotrochanteric line. sorry, and that connects your trochanters, the greater one and the lesser one, on the anterior side. And you can also have your trochanteric crest, which connect the trochanters once more, but is just on the posterior side. And there's also one tubercle here called the quadrate tubercle, but that's not too important, so I don't think you actually need to memorize that. Just telling you so you are aware of it. And now we'll have a look at the shaft of the femur. So this is the posterior side of the shaft, and you actually have a ridge or line of bone on the posterior surface, and we call that the linea aspera. So if we go proximally, so that's more superiorly, this will kind of split into two lips. On the medial lip, it will become the pectineal line, which is attachment for a muscle called pectineus. And on the lateral side, it will become the gluteal tuberosity, which your gluteus maximus attaches. If you go distally, they will form the supracondylar lines, and they will just go to your condyles. Not too important, the supracondylar lines, but I think these are nice to know. And then when we get to the end of the femur, we have our condyles. So you have a lateral and I have a medial condyle, and you also have your epicondyles, which is sort of the sides, and then your condyles are a bit more here on the bottom. And in the knee joint, they'll articulate with their respective meniscus. So you'll have two, one on the medial side and one on the lateral side, and they'll just sit here beneath it in the joint. You'll see the menisci later, so we'll worry about them a bit more later. And in the center, anteriorly, your condyles will merge to form a shallow depression, which is just sort of like a little valley where your patella will sit. And posteriorly, we have a bit more space, and we call that the intercondylar fossa, but not too important. And this is an image from Moore's anatomy textbook, just for your reference, so you can have a pause and just look at all of the labels if you like. And we'll talk a little bit about the patella. So this is a sesamoid bone, which is a bone within a tendon, and it's the largest one in your body. So it's located within the patellofemoral groove, which was that kind of depression we were talking about just before. It's the patello for the patella, obviously, and femoral for the femur. So this has two tendons that it's connected to. Superiorly, up here, as you can see here, is the quadriceps tendon, so that's your quads, which you might have heard before. And inferiorly, the patella tendon is down below. And this inserts onto the tibia, which is another bone here, which we'll also talk about, and it inserts onto a part called the tibial tuberosity. And so the patella will protect your knee, and it'll act as part of a lever as well for your quadriceps femoris. Not too important, but just so they'll tell you it's a lever, so good to know. And quickly, we'll just have a look at the movements of your hips. So if you turn your whole leg in and you point your toes in, that's called medial rotation. If you turn your whole leg outwards and point your toes out, that's called lateral rotation. If you put your leg upwards, this is called flexion. And if you pull it backwards in this direction, this is extension. And then abduction is if you move your leg away from your body laterally, and adduct is moving your leg medially. And now we'll talk a little bit about the hip joint. So this is a ball and socket joint composed of the acetabulum, which we mentioned before, and the femoral head. Kind of like the glenoid labrum, you also have an acetabular labrum. So that's a fibrocartilaginous ring, and that surrounds your acetabulum for stability because it'll make the joint sort of deeper, so it surrounds more of the femoral head. And something to know that is that there are also intracapsular ligaments and as well as extracapsular ligaments, and these just give stability, and they're spiral, so they'll tighten when the leg extends, and it helps prevent hyperextension. And I've put a lot of information here about the ligaments, but this really isn't too important, so you can read this in your own time if you like, but just basically know what they exist, and if you know the names, that's more than good enough in my opinion. But mostly what they do is they prevent hyperextension. And with the ligament of the head of the femur here, I would like to note that there is actually a branch of the obturator artery here, and it's called the artery to the head of the femur. Okay, now we'll talk a bit about the muscles. So you have basically three compartments of muscles. So they're separated by fascia, which is just basically connective tissue. And so you have your anterior compartment, and you also have a medial compartment, and you also have a posterior compartment. And we'll look at each of them in the compartments. But what's important about these compartments is that basically they all have their own innervation. So, for example, the anterior compartment will mostly be innervated by the femoral nerve. So we'll have a look at those later as well. But um, here we have the muscles of the anterior thigh. We'll start off with the iliopsoas. It's a big muscle, so iliopsoas, it consists of psoas major as well as iliacus. Also psoas minor, but you don't really hear much about psoas minor. It's quite a small muscle and it's not that significant. And we'll have a look at the picture here. So this is your iliopsoas. This one is your psoas major, and you can see that it's coming actually from the vertebral spine, whereas your iliacus is more coming from, well, yeah, the ilius. And together, when they fuse, they're known as iliopsoas. So the two muscles together are known as iliopsoas. You don't need to know the attachments exactly, just a general idea will do. But it's good to know the innervation, and we'll have a look at the nerves in more detail at the end. But basically, what iliopsoas does is it's a major hip flexor. So it does a lot of the work when you're flexing your hips. And now we'll have a look at pectineus. So pectineus, this one's from your superior pubic ramus, and it will insert onto the pectineal line, which I mentioned before. And the function is basically to adduct and flex the thigh, which kind of makes sense. If this shortens, it will pull and it will adduct. Next, we'll have sartorius. Sartorius does a lot of things. So we'll have a look. It originates from the aces here, and then it will insert all the way onto the medial tibia, which is this bone here. And if you think about what happens when it shortens, first of all, it'll flex the leg, it'll abduct, so that's pulling it outwards laterally, and it'll also laterally rotate the thigh, so it does a lot of things. And because this crosses the knee joint as well, it'll also have some flexion at the knee. And so some more pictures for you here, just to better visualize the muscles. And now we'll have a look at some other muscles of the anterior thigh. So this is your quadriceps femoris, which is commonly known as your quads and quite important muscle. So it's actually the fusion of four muscles. So what it really looks like is this, and what you have is sort of your rectus femoris on top, and then you'll have your three muscles beneath it. So beneath your rectus femoris, you have your rectus intermedius, and then on the medial side, you have your medialis, and on the lateral side, you have your lateralis. And so what they do is they really just extend the leg at your knee joint. So that's kind of pulling your shin forward, so to speak. And they form a common tendon, the quadriceps tendon, which we had a look with the patella, and it's also innervated in the femoral nerve. And here's some more pictures. This shows you all of the muscles we just looked at. And now we'll talk about the muscles of the medial thigh. So the medial thigh compartment is mostly adductors. So hence adductor longus, adductor brevis, adductor magnus, also gracilis, which also adducts, and you also have your obturator externus, which laterally rotates the thigh. So let's have a look at these muscles. But first, something to note is that the medial thigh, basically everything is innervated by the obturator nerve, so they'll come through the obturator canal. which you might not have seen yet, so it might be good to Google, just have a look quickly. Okay, so I think we'll go to this one because it shows it a bit more clearly. So on top is your adductor longus and then adductor brevis, and adductor magnus is sitting behind all of them, and it's the biggest one and it does the most work. So as you can see, they all sort of originate here from the body of the pubis, and they'll insert just onto the medial side of your femur, basically. And this is your obturator externus, so that's originating externally to your obturator foramen, which is right here. Normally there's a membrane covering this, which from the muscles originate from. And lastly is your gracilis. And gracilis. So this one's your gracilis. And so it originates from the inferior ramus of the pubis, and it'll insert medially onto your tibia. And something worth mentioning is that although just about everything is innervated by the obturator nerve, there is an exception, and that's the hamstring part of the adductor magnus. So the adductor magnus does have two parts. So let's see if we can find let's see if we can find a diagram that tells us that. So yeah, you can see, actually, yeah, it says here, so you can see that your adductor magnus, this part's the adductor part, and this part is the hamstring part. Not too much to know about it, except that they just have different innervations. And now we'll talk a bit about the muscles of the gluteal compartment, which basically is sort of surrounding the area of your butt. So we'll start with the gluteus muscles: gluteus maximus, gluteus medius, and gluteus minimus. So if we have a look, this is gluteus maximus. It sits on the most outer layer, and it will insert onto the iliac crest here. And then beneath that, if you take away gluteus maximus and you cut it off, there's the insert. Here is your gluteus medius. And if you take that one away again, then you get your gluteus minimus. And so your gluteus medius and gluteus minimus, where they insert is onto the greater trochanter here. But your gluteus maximus will actually insert into what's called the iliotibial tract, which is basically this long fibrous kind of ligament kind of thing. And that just sort of helps stabilize your leg. So just to note that gluteus maximus does not insert into the same place as medius and minimus. And medius and minimus will largely do the same thing. They'll abduct your leg and they'll medially rotate it as well. Gluteus maximus, however, on the other hand, it extends your thigh. And we'll have a look at tensor fasciae latae, which is this one here, and that also is part of the iliotibial tract here. And then there's your piriformis, which is here. So it originates on the sacrum, and then it will also insert onto the greater trochanter. And it will laterally rotate, extend the thigh, and when you flex your thigh, it will adduct. And then the gemellar muscles are these sort of small muscles here. So there's a superior one, and then in the middle of the superior and the inferior one is your obturator internus, which originates on the obturator membrane that we mentioned before, but just on the inside of the pelvis. And then you have your inferior gemellus below that. And then lastly, you have your quadratus femoris, which sits here, and it originates from the lateral border of the ischial tuberosity, and it'll insert onto the quadrate tubercle, which we did mention before, but that's not too important. And this also acts to laterally rotate the thigh. So yeah, I recommend you guys just to really look at some pictures, and it'll really give you a good idea of where everything sits. You don't need to know the exact insertions or exactly where they arise from again, but looking at just knowing where they are sort of can help you figure out what actions they do, because if you just imagine what happens when they shorten, then they'll sort of tell you what they do. As we mentioned before, the tensor fascia lata and gluteus maximus form the iliotibial tract, which is this fibrous connective tissue that runs down the side of your leg and it helps stabilize your leg. And then you have the muscles of the posterior thigh. So we'll start off with semitendinosus and semimembranosus. So yes, it's kind of hard to visualize here, but this one's your semitendinosus, and then below it is your semimembranosus. Might be a bit clearer here. So yeah, on the medial side of your body, you have your tendinosus and then your membranosus here. And on the other side, you have your biceps femoris. So you have two heads here, kind of just like the biceps in your arm. You have a long head and you have a short head. So semitendinosus, semimembranosus, both from ischiotuberosity, and they'll insert onto your tibia, so the medial part of the tibia. And these muscles are innervated by the sciatic nerve, which we'll have a look at later. And what they do is they extend the thigh. And when your leg is flexed, so when your knee is flexed, is what it's saying, it will rotate it medially. And then you have your biceps femoris, which also flexes your leg, and it rotates it laterally when your knee is flexed. Something a bit weird is that the conjoint tendon of sartorius, gracilis, and semitendinosus is known as your pes anserinus, which it translates to goose foot. I think it's like Latin or something. And so they all insert onto the medial part of the tibia, and I guess this is somehow supposed to look like a goose foot. And now we'll talk a little bit about the sciatic foramen. So if you have a look at the ligaments, the two important ligaments here are your sacrospinous ligament and your sacrotuberous ligament. So just by looking at the name, sacro means from the sacrum, tuberous means ischial tuberosity, so it will come from this sacrum towards ischial tuberosity. And then the sacrospinous ligament will go from the sacrum towards your ischial spine. And you can see how these two ligaments kind of form two holes here, and these are known as your sciatic foramen. So you have a greater sciatic foramen and you also have a lesser sciatic foramen, and we'll have a bunch of structures passing through these. And also this is obturator foramen that we were mentioning before, but normally, as I mentioned, there is a membrane covering most of this. There's only a little hole called the Obturator Canal. So the greater sciatic foramen. What happens is in the greater sciatic foramen, you have piriformis, which we mentioned before, that originates from your sacrum and it goes to the greater trochanter, and that will divide your greater sciatic foramen into a suprapiriform foramen and an infrapiriform foramen. And they will just have some different contents. We'll have your superior gluteal artery, vein, and nerve, and that will supply your gluteal region, as well as having your inferior gluteal artery, vein, and nerve coming from the infrapiriform foramen. But you also get some additional structures, including pudendal nerve, which is this yellow one here. It'll come out of the greater sciatic foramen here, and then it'll go through the lesser sciatic foramen back into your pelvis, and it'll innervate a bunch of your pelvic organs, which we won't look at obviously because you're not doing the pelvis right now. Thank goodness you're not doing the pelvis right now. And you also have your sciatic nerve, which is this long nerve here, and that was the one innervating most of your posterior thigh. So that was like your semitendinosus, um, semimembranosus, I believe. Yep, so the sciatic nerve here, and it's the tibial division. Not too important, the tibial division, you just sort of know it's the sciatic nerve. Okay. And then there's your lesser sciatic foramen, which has your obturator internus and your internal pudendal artery and vein, and the pudendal nerve, because as we mentioned, it comes back in through here. Yeah, so internal pudendal artery and vein as well is shown here, but that's not too important right now, so we'll leave that. And this is the obturator canal that I was talking about. So this is your membrane that covers your obturator foramen, and it leaves a small hole only, and through it you'll have your obturator nerve, artery and vessels. And the important thing to know about your obturator nerve is that that's what innervates your medial compartment, as we saw before. Inguinal ligament is quite important, so this travels from your ASIS, so your anterior superior iliac spine, towards your pubic tubercle. And here's a ligament, and under it you have some structures passing. So you will have your femoral nerve, which innervates your anterior compartment, and you have the artery and vein as well. You also have some lymphatics, and after it passes through this inguinal ligament, it enters an area known as the femoral triangle, which we'll talk about later. And some good points to know is that the midpoint of the inguinal ligament, so here, is where your femoral nerve is, and then just a bit more medial is the mid-inguinal point, and that's halfway between the ASIS and the pubic symphysis right here. And the midpoint is where you'll find your femoral artery, and that's called your mid-inguinal point. Now we'll talk about the femoral triangle, which we just mentioned. So this is this area in the leg here, in your thigh, anteriorly. And we'll talk a little bit about the boundaries first. So superiorly is your inguinal ligament, and then laterally is the muscle here, sartorius, which you had a look at before, and it's a medial border of sartorius. Some sources do argue it's a lateral border, but we've been taught as the medial border. And then the roof, which is sort of this layer, this anterior layer, is some fascia, basically. The fascia lata, deep fascia, whatever you would like to call it. Not too important, it's just fascia. And then the floor is some more muscles. It includes the iliopsoas and the pectineus, which we can't really see these muscles too well here, and also the adductor longus. So we can't really see them too well here, but that's okay. And then the contents of the femoral triangle are also important to know. You can remember them as the acronym NAVAL, from lateral to medial. So that starts with your femoral nerve here, and then your femoral artery and vein, and then empty space is the E, and then lymphatics, which is in something called the femoral canal. Alright, so as you can see, the vasculature and the lymphatics here are within a fascia, right? This part is all fascia, and there's 3 different compartments in this fascia, which is called the femoral sheath. The lateral compartment is what has the femoral artery, the intermediate compartment has the femoral vein, and the medial compartment contains lymphatics, some loose connective tissue, which is basically fat, and also some inguinal nodes, so the deep inguinal lymph node. And this most medial one is called the femoral canal, this most medial compartment. And then here is the sheath boundaries. I've just given it here, but I've never really committed to the memory. I don't think it's too important. And the femoral ring is the superior opening at the abdominal end. Let's see. Not sure if it labels it here. Femoral vein. Doesn't appear as labeled here, so I think we'll move on. But basically, the femoral ring is the opening of everything at the abdominal end. Alright, so now we'll move on to the bones well, kind of like the shin bones, basically. So we'll talk about the tibia first. So we'll have a medial condyle and lateral condyle, and these are a bit flatter because they need to bear weight from the femur. And you have some tubercles in the middle, which aren't too important to know, but there's also sort of three surfaces and borders for the tibia, which also isn't that important, but basically you have your medial surface here, you have your lateral surface. So your medial surface you can just really feel if you just feel the medial side of your shin and you can feel the bone, that's your medial surface. And apart from that, we also have a posterior surface. A landmark we should know is the tibial tuberosity, which is where the patella ligament inserts, and it's right here. And between the tibia and this other bone here called the fibula is an interosseous membrane. And on the posterior surface, we have something called the soleal line, which is attachment for a muscle called soleus, as we'll see, but that's not important. Right, that's not too important. There's a landmark. Distal, we have the medial malleolus, which is important. Yeah, it's just sort of like a projection. And over here we have the fibula. So the fibula doesn't bear any weight, as you can see, it's quite thin. It's basically just used for muscle attachment. All of the weight bearing is done through the tibia. And you can see that this forms a lateral malleolus, and you can feel your malleoli. So if you touch your ankles and you feel the two sort of rounded protrusions on either side of your ankle, those are your malleoli, and you can feel them just like you can feel your ischial tuberosity. You can feel your ACIS as well, and you can feel your greater trochanter. So if you want to feel your ACIS, it's basically the most front part of the hip. If you move your hand there and you just feel for bone just beneath the surface, that's your ACIS. And now we'll talk about the hip joint. Sorry, not the hip joint, the knee joint. So this is a hinge joint, so it will only basically flex or extend. There's a small amount of rotation, but it's fairly negligible. And we have three bones articulating. We have the femur, this one, and we have the tibia, the one below, and we have the patella. And the tibial femoral part is where the condyles of the femur will articulate with the tibial condyles, or the plateau, because it's so flat, you can call it a plateau, and this is the weight-bearing part. And the patellofemoral part is just where the femur contacts the patella. And now we'll talk about the menisci. They're quite important. So these are fibral cartilage discs, basically. And they'll deepen the articular surface. So this part is a bit higher, the medial part's a bit lower, and they'll give your tibia some more stability. They also act as shock absorbers. They're C-shaped, as you can see, and they attach to the intercondylar area here. The medial meniscus, to note, is also attached to the medial collateral ligament, the joint capsule, and also actually the anterior cruciate ligament, which I haven't written down here, but it is. So this is your anterior cruciate ligament. So when one is injured and torn, you can actually also tear your anterior cruciate ligament, which is ACL. You might hear them talking about that on TV. And also your medial collateral ligament. So this injury is the happy triad, so you can injure all three of these things. And your lateral meniscus is a bit smaller, and it doesn't have these attachments it doesn't attach to other things like the medial meniscus does. Now we'll talk about collateral ligaments. So you have medial collateral ligaments and you have a lateral collateral ligament. And they basically attach from the epicondyle of the femur onto the tibia condyle or the fibula head. And so they prevent excessive medial and lateral movements of the knee and keep it as a hinge motion. So if we look at the medial collateral ligament, you can imagine that if we were to move the shin this way laterally, that this would stretch the ligament, and that's what it's opposing, right? So it's opposing lateral movement of the tibia and the fibula, and this is what we call varus force. And the lateral collateral ligament opposes forces moving tibia and fibula medially, right? And we label this as valgus force. And so if you have too much of these forces, you can actually injure these ligaments as well. All right, now we'll talk about the cruciate ligaments. So the cruciate ligaments connect the tibia and the femur, and they cross each other, so they're known as the cruciate ligaments because cruciate means cross. The anterior cruciate ligament attaches at the anterior intercondylar region here, where it blends with the medial meniscus as we mentioned, and it will send posteriorly to attach to the femur in the intercondylar fossa. And what this does, it prevents anterior dislocation. So if you imagine that you pull this tibia forward, you can see how this might prevent, how this might get stretched and try to prevent that anterior dislocation. The posterior cruciate ligament, it attaches at the posterior part of the intercondylar region, and it will ascend anteriorly to attach to anterior medial femoral condyle. And this one instead prevents posterior dislocation. So if we try to push the tibia backwards, this ligament would try to stop him. And something to note that you can do to remember the direction of the how the posterior cruciate ligament travels is something called palm. So it travels posterior to anterior, PA, and it travels lateral to medial. So you also know that the ACL is the opposite because they cross each other, so it must travel anterior to posterior and medial to lateral. So that's how you kind of remember the directions. And just another diagram here for your reference. And now we'll talk about some of the bones of the feet. So talus is this yellow one. It's the most superior one. It helps transmit the weight to another bone below it called the calcaneus, which is in purple. It has 3 articulations. Superiorly, it forms the ankle joint with the tibia and the fibula, and we call this the talocrural joint, which is the ankle joint. Inferiorly, we have the subtalar joint, which is with the calcaneus. And then anteriorly, you can see it also intersects with this blue bone called the navicular bone. Navicular is supposed to mean boat, I think. Somehow this is supposed to look like a boat. And it's called the talonavicular joint. So the calcaneus is this purple one, and it's actually the largest tarsal bone because it bears so much weight. And it has 2 articulations, the subtalar joint we've already mentioned, and anteriorly it has the calcaneocuboid joint, which is this green bone, with the green bone here, the cuboid bone. And something that you should know is that the calcaneus, where it protrudes posteriorly, is known as the calcaneal tuberosity. And this is where the Achilles tendon will attach. Alright, the navicular bone we've mentioned. So it will articulate with the talus, the cuneiform bones, which are in red, and there's 3 of them, as well as the cuboid bone. The cuboid bone is the green one here, and it will articulate with the 4th and 5th metatarsals, which are these 2. The cuneiforms are these 3 bones here. There is a medial one, and an intermediate one, and also a lateral one. Alright, metatarsals. Pretty similar to your hands, so they have a head, neck, shaft, and base. And they can have either 3 or 4 articulations, so they can have tarsal metatarsal joints, so that's between the tarsal bones, which are all of these bones, and the metatarsals. You can have intermetatarsal joints, so between each metatarsal, and it can also have metatarsal phalangeal joints. This isn't too important, so you can sort of ignore that, to be honest. You can also have your phalanges, your phalanx. So you can see that you have a proximal one, a middle one, and a distal one. But something to note is that the first digit only has a proximal and distal one. Some more pictures for your reference. There's a lot of labels though, so just get a general idea, I would say, is good enough, I think. I really just memorized that this was the calcaneal tuberosity. Alright, time to have a look at the ligaments of the ankle. So the medial ligaments is made of 4 parts, which fan out from the medial malleolus here, and it will attach to the talus, the calcaneus, and the navicular bone. So there's a tibial navicular part, which is between the tibia and the navicular, obviously, the tibial calcaneal, and anterior and posterior tibial talar parts as well. So the name tells you where they go. And the main function is to resist over eversion of the foot. So eversion is if you try to move your foot laterally, your whole foot, that is eversion. So it'll prevent over eversion. The lateral ligaments have three separate lateral ligaments, unlike the medial ligaments, which all sort of band together. These ones are separate, and they originate from the lateral ligaments. So you have anterior talofibular joint, which is from the talus here and the fibula here. And you also have a posterior talofibular joint, and you also have a calcaneofibular joint. So your lateral ligaments prevent over inversion, which is if you move your feet inwards medially, that is inversion. And as you can just try on yourself, you can see that you can invert your foot much further than you can evert your foot. So actually, your lateral ligaments are often much more injured much more often compared to your medial ligaments, which is basically what we're talking about here. So in a medial strain, the ligaments primarily sprained is the deltoid ligaments, so these ones are also called the deltoid ligaments together. And this is only 20% of ankle sprains because the lateral ligaments are the ones that get damaged most of the time because you can invert your feet so much more. You can also have syndesmosis injuries. So the syndesmosis is the interosseous membrane between your tibia and your fibula. And yeah, just know that exists basically. Alright, now we move on to compartments of the lower thigh. So you have an anterior compartment, a lateral one. You have two posterior compartments actually. You have a deep compartment and you have a superficial compartment. And these are some GIFs that show you how the feet move. And these were made by PSPeppa, so all credits to them. They are a pretty incredible PSP, so they're for our year. If you want to access to this stuff, send us a message. They're quite useful. So dorsiflexion is basically when you bring your feet upwards towards your shin. Plantar flexion is you point your foot downwards, basically. Inversion is where you move your feet in medially. Eversion is outwards, laterally. Alright, in the anterior compartment, let's start with tibialis anterior. So this is quite important for dorsiflexing your ankle or your foot, and it'll also do some inversion. Once again, not too important to know exactly where they're attached. Some general idea is good enough. So this is your tibialis anterior, and as you can see, its tendon actually goes to the medial bottom side of your foot, which is why it can also help you invert as well as dorsiflex. And then this is your extensor digitorum longus and extensor hallucis longus, and these will basically just extend your toes. We also have another one here called peroneus tertius or fibularis tertius. Peroneus is the old name for fibularis, but they've changed the name now. And this one dorsiflexes the ankle as well, and it also aids in some eversion because, as you can see, it's on the lateral side. So because it's attaching pretty laterally, it will help with eversion. And these are all innervated by the deep fibular nerve. And you have your lateral compartment now. And what these do is they evert the foot, which makes sense, and they can also weakly plantar flex the ankle. So let's see. Fibularis longus and fibularis brevis. So as you can see, they attach to the side here and they will help you evert, and you can see the muscles here. So the fibularis longus is more superficial, and then fibularis brevis here is more deep. Alright, superficial muscles of posterior compartment of the leg include your gastrocnemius, your soleus, and your plantaris. And these are all innervated by the tibial nerve. And what they do mostly is they just plantar flex Plantaris isn't so strong, it just weakly assists in plantar flexing the ankle. So, most superficially is your gastrocnemius, and it has two heads, a medial head and a lateral head. And it attaches to femur and then attaches to calcaneus. So, their ligament here is actually the Achilles ligament, and it will fuse with the soleus's ligament. And the soleus ligament, it attaches here to the fibular head and also to that calcaneal tuberosity, forming the Achilles tendon, and it's a bit more deep. And something to note that is because the gastrocnemius attaches to femur, if you flex your knees, so if you bring your shin up or behind you to your butt, gastrocnemius is too long, right? And it can't plantarflex. It can't help you plantarflex because if you bring your if you flex your knee, that's shortening the distance between basically here and here, and so the muscle will become basically too flaccid, and even when it contracts, it won't be able to pull and plantarflex enough. So it can only really plantarflex effectively when your leg is extended. Plantaris, you can see here, it attaches to the back of your femur as well, and it'll also attach here, but it's really not that strong of a muscle, and it only weakly plantarflexes. And now we'll move to the deep posterior compartment. Alright, let's start off with the innervation. As you can see, they're innervated all by the tibial nerve once more. And tibialis posterior, let's see, tibialis posterior, you can see here. So they sort of attach more to the base of your foot or beneath your foot, as you can see here. And so tibialis posterior will plantarflex your ankle, and it will also invert your ankle because, as you can see, it's more on the medial side, and this will help you invert your ankle. Flexor hallucis longus, flexor digitorum longus they just do what their name suggests. So they flex the digits. So digitorum, digits 2 to 5, and hallucis is your big toe. So this flexes your great toe. Popliteus, this one weakly flexes your knee. And here it is. So you'll weakly flex your knee. It attaches from the lateral condyle here and just attaches onto the back of the tibia. Alright, now let's talk about the popliteal fossa. So this is the back of your knee. It's a diamond-shaped area by the muscles. So let's have a look at the borders, right? So this is your superior medial border here, and that's formed by your semimembranosus muscle. The inferior medial borders here is formed by the medial head of the gastrocnemius, and the lateral border is formed by the lateral border of the gastrocnemius, as well as plantaris. And then the superior lateral border here is formed by your biceps femoris. The floor is formed by the knee joint capsule, the popliteus muscle, and posterior femur. That's not too important to know the floor. The roof is made of 2 layers, the popliteal fascia and the skin as well. And something to note is the popliteal fascia is basically a continuation of your fascia lata that I mentioned before, and it will continue as the crural fascia. Not too important to know what the fascia, about the fascia right now, but just, it's fascia. You'll learn more about it as you go. And then let's have a look at the contents. So you have your popliteal artery here, your popliteal vein as well. You have your tibial nerve, and you have a common fibular nerve. And we'll have a look at these structures more at the end, so don't worry if you don't know them now. But something to note is that the common fibular nerve, it follows biceps femoris, this border of biceps femoris. And the deepest structure here is the popliteal artery, which is a continuation of the femoral artery higher above. And there's also a small saphenous vein that will drain into the popliteal vein. It will actually pierce the popliteal fascia, and it comes more superficially, but we can't see that right now, so don't worry about it too much. It's not an especially important vein. And now the muscles of the foot, the sole of the foot. It's honestly a lot to remember, and I didn't commit all of them to memory, so if you just have a general idea of what they are, and if you're just aware of them, that will be enough. Unless, of course, you're a perfectionist, which many students tend to be because we're doing med. Anyways. Alright, abductor hallucis. So it'll abduct. Hallucis is the big foot, so big toe, sorry. It'll adduct the first digit. And we'll see if we can find it. Adductor hallucis here. So it'll come from the calcaneus and it'll insert here. And you can see how that would abduct the big foot. Flexor digitorum brevis. So this also flexes your toes. And abductor digiti minimi here will abduct your most small toe. And this is the first layer, so there's actually, I think, 4 layers of muscles in the sole, which make it even harder to memorize, which is why I did not bother. And then we also have quadratus plantae and lumbricals. So your quadratus plantae will, let's see, quadratus plantae here. And this basically helps flex. So this pulls on the tendons of digitorum longus and it will help flex. And you have your lumbricals here. And what your lumbricals do is they flex your proximal phalanges and they extend your middle and distal phalanges. So kind of like the ones in your fingers, if you remember them. And then the third and fourth layer. Alright, flexor hallucis brevis. So, as the name suggests, it flexes your big toe. And then you also have adductor hallucis. And this actually has 2 heads. So it has a transverse head and it has an oblique head. And as the name suggests, it just adducts your big toe. And then you also have flexor digiti minimi brevis, and this will flex your smallest digit. And then you have your interossei. You have some dorsal interossei as well. A dorsal interossei, which is like the top surface, the superior surface of your foot, and the plantar is like the sole. So that's more on the bottom inferior side of your foot. And your interossei here. So the plantar interossei adduct the digits 3 to 5, and they flex your metatarsal phalangeal joints, which is between your metatarsals and your phalanx. And your dorsal interossei, they abduct the digits 2 to 4, and they flex your metatarsal phalangeal joints. And just more diagrams here for your reference. Okay. The dorsum of the foot. Luckily, we don't have as many muscles. So the dorsum of your foot, basically what they do is they just extend your digits. So extensor hallucis will extend your big toe, extensor digitorum brevis will extend the other ones. So yeah, they aid your extensor digitorum longus in extending the 4 medial toes. And these are innervated by your deep fibular nerve. More pictures here. So, extensor digitorum brevis and extensor hallucis as well, which we can't really see too. Extensor hallucis here, sorry. And then these ones are your brevis, digitorum ones. Alright, an important passageway to know is the tarsal tunnel, which is on the medial side of your ankle. And it's a passageway for things to enter from the back of your leg, your calves basically, into the sole. And it's all because we have this flexor retinaculum here, which is kind of like the flexor retinaculum in your wrist, if you remember, in your upper limb. So the roof is made by the flexor retinaculum from your medial malleolus to the medial calcaneal process, and the plantar aponeurosis, which is some connective tissue on the plantar side of your foot. And medially, it is your medial malleolus here. Laterally, it's the posterior talus and the calcaneus. And the floor is the medial surface of the tibia, the talus, and the calcaneus. And so there's a lot of contents to come here. Your tibialis posterior tendon, your flexor digitorum longus tendon, there's your posterior tibial neurovasculature. I won't list them all, you can read them. But a good acronym to remember all of them is Tom, Dick, and Very Nervous Harry. So Tom, tibialis posterior tendon. Dick for digitorum longus, and is the artery. V is the vein. Nervous is nerve, and Harry is oh, I've got the spelling wrong here, sorry about that. Hallucis longus tendon. Alright, now we'll talk a bit about the nerves. And firstly we'll talk about the femoral nerve, which is mostly for your anterior thigh. It's quite important. So it's L2 to L4, that's its roots, and it travels from the abdomen through the psoas major, and it passes underneath the inguinal ligament here to enter the femoral triangle. And after it enters the femoral triangle, a bit below the inguinal ligament, it will divide into some divisions. It will have an anterior division and a posterior division. So the anterior division will give some cutaneous branches for sensory innervation, and it will also branch to sartorius and pectineus to innervate them. Not too important. Posterior division will give you the saphenous nerve, which we see here, and this actually gives sensory innervation to the medial side of your calves. And this will also innervate your quadriceps femoralis, but not too important to know these divisions and particularly exactly what muscles they innervate. Just know that they innervate the anterior compartment together and that you have the saphenous nerve. So motor function, it will be your hip flexors as well as your knee extensors. Sensory function, it will give you the cutaneous branches for your anterior medial thigh for sensory function, and the saphenous nerve, which is a continuation of the femoral nerve, supplies the medial leg and the foot. Adductor canal. So this is basically a tunnel which runs from, it just runs through here. So it runs to a hole in the adductor magnus. So your adductor magnus, where it attaches, actually has a hole here, which is called the adductor hiatus. And all the muscles here around it form this tunnel, and you can have structures running all the way through to this adductor hiatus, and that will let it pass into the back of the leg, basically, and into your calf. So the anterior medial border is your sartorius. Oh, sorry. I think these are mixed around. So this is your lateral border. Sorry about that. The lateral border is your sartorius. The anterior medial border is your vastus medialis, and posteriorly, so behind this is your adductor longus and your adductor magnus. So the contents here that run through are the posterior artery and vein, nerve to vastus medialis, not too important, your saphenous vein, and so your artery and vein, right, the femoral artery and vein, they become the popliteal artery and vein after exiting through the canal. Alright, just quickly mentioning the obturator nerve. So the obturator nerve basically originates here, and then it runs through your pelvis and it will go through the obturator canal. So it will descend through the fibers of psoas major, and then it will travel along the pelvic wall laterally towards obturator foramen, and then after it exits the obturator canal, it will innervate the medial thigh. And the motor functions are basically innervating the medial compartment of the thigh, and the sensory function also innervates the medial thigh, so it'll give us some cutaneous branches. Alright, sciatic nerve, which is the major nerve of the back of your leg, basically. Roots of L4 to L3. And so it enters the gluteal region, the back of your thigh, through the greater sciatic foramen, and it emerges inferiorly to the piriform, so it's from the infrapiriform foramen. And then it enters the posterior thigh, and later it will bifurcate here into the tibial and the common fibular nerve just before the popliteal fossa, and it innervates the posterior compartment of the thigh. Alright, the tibial nerve, which is a branch of the sciatic nervous continuation here, and that innervates basically the back of your calf. So it arises at the apex of your popliteal fossa, it travels through and down posterior to the tibia, and at the foot it will go into the tarsal tunnel, which we've discussed, and immediately distal to the tarsal tunnel it will terminate into sensory branches here. You have a medial one and a lateral one here. And motor-wise, it innervates all the muscles in the posterior compartment of your lower leg, which is your calves, basically. And sensory-wise, it does several things. So when it's in the popliteal fossa, it'll give off a cutaneous branch, and that will later combine with a branch from the common fibular nerve here to form the sural nerve. And this will supply the posterior lateral side of the leg and the lateral side of the foot. And this also supplies the sole via 3 branches. You'll have a medial calcaneal branch, which we can't see here right now, but you'll also have a medial plantar one and a lateral plantar nerve. And yeah, so you can read this here. Alright, common fibular nerve, the other branch from your tibial nerve. So it follows the medial border of biceps femoris over the lateral head of gastrocnemius. So at this point, it gives off 2 branches. And then it will then enter the lateral compartment by wrapping around the fibular neck, passing under fibularis longus, and terminating into the superficial and deep fibular nerve. So you can see the deep fibular nerve here and the superficial nerve here. Okay, so the superficial fibular nerve will innervate the lateral compartment of the leg, and the deep fibular nerve will innervate the anterior compartment of the leg. Sensory function-wise, we did mention the sural communicating nerve, which combines with the branch of the tibial nerve we just mentioned to form the sural nerve, and that will do the lateral part of the leg, the posterior lateral leg. And you also have a lateral sural cutaneous nerve, which is a bit different, which does the upper lateral leg. So this is different to the sural nerve, I believe, from memory, if I recall correctly. And we've mentioned that the superficial fibular nerve that we mentioned innervates the skin of the anterior lateral leg, and also the dorsum of the foot, so the whole dorsum of the foot, the top side, except between the first and second toe, the deep fibular nerve. So this is a very important clinical point which you will be asked about. The webbing between the first and second toe is actually innervated by the deep fibular nerve. And this is a diagram showing you the dermatomes, well, not the dermatomes, but the areas that they innervate. So your lateral sural is upper lateral. Your sural nerve is posterior lateral, more inferiorly. Your saphenous, which comes from your femoral nerve, the continuation does the medial side. And you also have your deep fibular nerve between the first and second toe, which is quite important to know. And there you have the superficial nerve, which does the anterior lateral side and the whole dorsum of the foot, basically. more reference here. Now we'll talk about the vasculature. So the femoral artery. Alright, so the femoral artery is a continuation of the external iliac artery, and it becomes femoral artery only after crossing the inguinal ligament, and it will give a branch called the profunda femoris artery, which is basically the deep femoral artery, is another name for it. And this travels posteriorly and distally, and it gives some branches. So there's some perforating branches, which perforate the adductor magnus. So we'll go back. I'm not sure how. Yeah, we'll just go back to here. So you can see that there's actually like a little hole here. So the perforating branches will actually perforate all of these holes. There should be more holes here. There aren't, but they will perforate that basically. And then you also have your lateral femoral circumflex artery and your medial femoral circumflex artery. And this is quite important for supplying the neck of the femur, the head and the neck. This is quite important, which we'll touch on later. And then once it's done all of that, the femoral artery will continue down the adductor canal, which we mentioned before, and it becomes a popliteal artery into the popliteal fossa once it moves through the adductor hiatus. Alright, the obturator artery basically is arising from the internal iliac artery, and it follows the obturator membrane and it goes through the canal to enter the medial thigh, and it has bifurcation. So there's an anterior branch, which kind of basically supply the medial thigh, and you also have a posterior branch which supplies some of the deep gluteal muscles, so that's more posterior, that's like your butt basically. Okay, gluteal arteries. So this also arises from the internal iliac vein, artery, sorry, and it enters the gluteal origin via the greater sciatic foramen. So it can, once again, it can be above the peripheral muscle or below the peripheral muscle. Above is superior gluteal artery, below is inferior gluteal artery. And so these just supply the gluteal region, basically. All right, popliteal artery. So this is the continuation of the femoral artery, and it moves through the popliteal fossa, and at the lower end of the popliteal fossa, it divides into the anterior tibial artery and the tibial peroneal trunk, which is right here. But very quickly, the tibial peroneal trunk will divide into your posterior tibial artery and your fibular artery. So the posterior tibial artery will keep continuing down the deep posterior leg muscles, and it will enter the sole of the foot by the tarsal tunnel once more. Whereas your fibular artery will just descend posteriorly to the fibula within the posterior compartment, and it will give rise to some perforating branches, which basically supply the lateral compartments of the leg. And then your anterior tibial artery will eventually become the dorsalis pedis artery on the dorsum of your foot, which we will see just now. So the dorsalis pedis, anterior of the continuation of the anterior tibial artery, right here. And it'll form this little arch here called the arcuate artery, and it'll also have a deep plantar artery which goes to another arch called the deep plantar arch. Yeah, so basically passes through the dorsal aspect of the tarsal bones. Is there anything I want to add? Not really. And your posterior tibial artery here from the tarsal tunnel will split into lateral and medial plantar arteries, and it will also supply this deep plantar arch, which has a branch here from the dorsalis pedis, which is the deep plantar artery. Alright, so pulses. There are a few pulses for clinical skills that you'll need to know. So the femoral pulse can be palpated as it enters a femoral triangle at the mid-inguinal point. So that's midway between your anterior superior iliac spine, your ASIS, and the pubic symphysis. And this another one's the popliteal artery. This is quite hard to feel because your popliteal fascia is quite rigid and it lies kind of deep in the popliteal fossa. So what you can do is you can get the patient to flex their knee, so that will basically bend the knee and that will help relax the fascia, but you'll need to feel quite deeply, and often you might not actually be able to feel this artery. And then you have your dorsalis pedis pulse, which is just found just lateral to the extensor hallucis longus and distal to the navicular bone. So let's see if we can find. So just about here, we can't see the tendon, but this is just dorsal to the navicular bone. And it's helpful to search up a video on YouTube, and that can sort of help you find where it is on yourself. And then the posterior tibial pulse can be palpated infraposteriorly to the medial malleolus, basically where near the tarsal tunnel, basically, where it just enters the foot. So this one I do remember doing it myself. So you can, if you can find a video, you can try that on yourself as well. And now we'll talk about some clinical syndromes, and we're almost to the end, guys. So just hang in there. So we mentioned the sciatic nerve travels below the piriformis. The piriformis can actually compress the sciatic nerve to bother it, and sometimes you'll actually see some anatomic variation where the sciatic nerve goes into the piriformis, like it kind of splits it in half almost. It just goes through the piriformis, and so this will give you some radiculate pain, and it'll give you some numbness, it'll give you some muscle weakness, and it'll give you some butt tenderness as well. Usually you won't find much on the X-rays or MRI, and there's two treatments. You can do it non-operatively or you can do it operatively. So if it's not too bad, you can just give analgesia like painkillers, do some physiotherapy and corticosteroids for inflammation. Operatively is basically doing surgery, and you're just, cutting away the piriformis, a little bit of the piriformis to help relieve the sciatic nerve. Another one is the popliteal aneurysm, which you can see here. So you can have an aneurysm of the popliteal artery, and because your popliteal fascia is quite tough and it won't expand much, what happens is your popliteal artery will compress your other contents. So you can compress the tibial nerve, and that will result in a weakened and absent plantar flexion, as well as parasphagia of the foot, which really should be the foot, and the posterior lateral leg. And the aneurysm you'll obviously be able to feel from the pulsation. This one's quite extreme. Normally it might not bulge up this much, but you can also hear an arterial bruit. Alright, femoral neck fractures. Femoral neck fractures are quite important. So the neck is quite narrow, and it's actually at a joint, at an angle where like it's perpendicular to gravity, so it bears a lot of gravity's weight, a lot of your weight, and you can often get fractures as a result of high impact trauma, so something like a car crash. Normally not just if you're playing rugby or something, because your bones are quite strong. These bones are quite strong. But the important thing to note here is that the blood supply is retrograde. Much like the bone in your hand. I can't quite remember its name. I'm just having a mental blank. But if you remember the retrograde flow of the bone in your hand, it's similar to this. So retrograde flow is by your lateral femoral and your medial femoral circumflex arteries, and it gives rise to your retinacular arteries. And following a fracture, these can all be ripped, and sometimes the only blood remaining is the one coming from the artery of the ligament of the head of the femoral of the femur. And this really doesn't give much blood at all. I think it degenerates a bit after birth or during development, embryological development, so it really doesn't give much blood. And because you don't get much blood, you can have osteonecrosis. So when you do get a femoral neck fracture, the affected leg is externally rotated like this one here, and it is pulled up a little bit as well, so it might be a bit shorter. So treatment, you don't really need to know the details, but it's basically operations to have the pins and screws. And if it's really bad and it seems like it might osteonecrose, you might get a hip replacement. Next thing that's important is meniscal tear. So the medial meniscus is joined to the ACL and tibial collateral ligament, as we mentioned before. So when the medial meniscus gets injured, they can all get injured together. So this is a happy triad. And the thing about the meniscus is that because it's weight bearing, you don't really have any nerves or vascular supply there because otherwise it just gets squashed, right? So because you don't have any vascular supply, it often gets poor healing if you do tear it. So you can tear it typically. That's by excessive rotational forces with the foot planted. So if you're playing sports and you're suddenly trying to turn around, and what might happen when you get a tear is you can hear a pop, but there might not be any obvious signs immediately, but after several days you can get some pain, swelling, stiffness, and giving way because your knee joint's no longer stable. And if a piece of meniscus comes loose, it can lodge itself into the joint, and it won't let your joint move well, and it will lock the joint, so you might be unable to bend your leg, for example. And I think that actually marks the end of the presentation. Um, Good luck, guys. If you have any questions, please just message us. And enjoy your day.